One of the things, and I have been involved in the nesitubimab trials, and we've had the same criticism with these trials is the magnitude of the benefit. We have this, ASCO defining what a clinically meaningful benefit is. And both RAM and Nessie didn't quite make that milestone, if you will. I like Corey Langer's statement that these should be aspirations, not guidelines. But your perspective on the magnitude of the benefit. I also want to get Roy's perspective in this setting, and just how does this fit in the lung cancer landscape?
Well, first, I know, Roy, you were involved with those guidelines, but nivolumab and pembrolizumab also, or at least nivolumab in its approved indication also did not reach the ASCO goals, although in all fairness in a second-line setting, whereas these goals were in a front-line setting. These have not been goals that have been easy to reach. That being said, that it has been a criticism that people have had, and I understand that criticism. We want to have tremendous benefit with a new drug that's approved. And there's obviously an expense issue as well, which is that these are costly agents. And so that plays in as well. I think it's very hard to indicate what is a meaningful survival benefit. I think you need to take things on their totality. What is the additional toxicity? As you point out, there weren't any new terrible safety toxicities. Things like neutropenia were certainly increased. But again, I think one has to take it on its totality in terms of what are the costs and what are the benefits of the agent. The other thing that I'll put in, which does get to something that Roy mentioned earlier about biomarkers, one has to remember that the BR21 study, which showed a benefit to erlotinib and made erlotinib available, had very similar survival benefit to what was seen with both of these agents. And that now, in retrospect, we consider erlotinib to be a very significant drug in the treatment landscape in lung cancer, although it is because we were able to, we as a lung cancer community, largely through Tony Mock's IPATH study, were able to clearly identify a biomarker and were able to select the appropriate populations. And so certainly there continues to be hope that that will be something that can be done with that. But in the end, I think that it is helpful for practitioners to have these options and to discuss them with their patients and to discuss the benefits and the risks of any agent they would be looking at.
Roy, your perspective on the clinically meaningful benefit?
Yeah, so about 2-3 years ago now, we sat down, at ASCO and a number of tumor types. It was done for GI cancers as well, and lung and a few others, and looked at what would be a hazard ratio, what would be considered clinically meaningful. And you're right, Eddie, that was in the frontline setting. And I believe we had a hazard ratio about 0.75 after looking at a lot of data. Again, you have to look at every trial on its merits. It's the toxicity, in relation to that value that's going to make a difference. And again, are there subsets that benefit more? I think as far as the ramucirumab goes, it was a second-line trial. I was impressed. The fact that something could be added to docetaxel, between the three of us who, and you've done some, you know, lung cancer. And Joanna, you missed in phase 1. I guess we all have. How many trials have we looked at where you couldn't add to docetaxel? Right. And the fact that this drug could be added to docetaxel both in non-squamous and squamous cell cancer. So that I think is good. The hazard ratio, is it a home run? No. Is it incremental progress? Yes. I think the most important thing is, we talk about immunotherapy. It looks great, but still in lung cancer, only a quarter of the patients. What about the rest? This gave us a drug that is now available to us for those patients who don't have other options, and it's a little bit better than the chemotherapy alone. And then it gives us the drug to now figure out how to use it better. And I think one thing we have to do now is we get more experience with the drug and people are in practice, how can we add this to the immunotherapy? How can we add this to other regimens? How can we develop a biomarker? The hardest thing about the angiogenesis has been, we're really doing an indirect targeting here. Although, because this is VEGF mostly on the endothelial cells, though certain tumor types do have, VEGF receptor on the tumor cells as well. But, it works a little bit. We can figure out how to make it work more. We can look at combinations. But, we need these small steps and the big steps, both. Though, hazard ratio, what was it, 0.84?
8.6.
8.6. It's, again, across the population, but if it's you or me or your family, you want to have something to offer. So it's tough, and we're in tough times now economically. So we have to look at all that, but if there's nothing else left to offer, I think this is reasonable.
So Eddie, I wanted to ask you that there were I think, 14% of people who had prior Bev, and that didn't seem to matter. What's that telling us about these two agents?
So as you point out, it was a small subset, and so it's hard to make definitive conclusions. But what it would indicate is that there's clearly no data that would say that the benefits are not going to extend to that group of people, although one also, based on the data available, can't definitively say that the benefits would extend to them either. Of course, whenever one looks at a subset analysis of a study, you're going to get a subset or a smaller group. So it makes it more difficult to definitively state that you're going to have a benefit. But clearly, that was a group that was included, and there's no data to say that that group would not benefit. And you've already heard much of the data from the GI cancers, where continuing this is just part of their established armamentarium of therapy.